So it's my pleasure to introduce our speaker today. Dr. Aaron Grubbs received his medical degree from the Medical University of South Carolina. He completed residency in internal medicine and pediatrics at the University of Alabama at Birmingham. He also completed a fellowship in adult and pediatric infectious diseases at the University of Alabama in Birmingham. He is now an assistant professor at the University of Kentucky, where he works as an infectious disease physician. He is certified with the American Board of Internal Medicine, Infectious Diseases, and the American Board of Pediatrics, Pediatric Infectious Diseases. So everyone, please welcome Dr. Grubbs.
Here are slides. Wonderful. So as he said, my name's Aaron Grubbs. I'm one of the infectious diseases doctors here at the University of Kentucky. And I'm happy to be able to talk with you guys today. It's helpful to see that participant poll at the beginning just to know more about the folks that are in the audience and everything. And I tried to make this presentation more geared for a non-physician audience and all. In terms of disclosures, I don't have any financial disclosures for this presentation. So for learning objectives, we would like, upon the completion of the presentation, for you to be able to describe sort of the early history of HIV and hepatitis C and their association with substance use disorder, and then also express current epidemiologic trends with HIV and hepatitis C and substance use disorder. And on broad terms, talk about the transmission, pathogenesis, treatment, and prevention of HIV, and then the same for hepatitis C. So I thought it would be helpful to talk about a timeline for both HIV and for hepatitis C, because I think that it demonstrates a good bit about how these infections have been associated with substance use disorder, even from some of the early stages of when they were first recognized. And so for HIV and AIDS, starting in 1981, in June, there was a case series that was published in the MMWR, and it was a series of 5 young men who had sex with men who had pneumocystis pneumonia, which was an odd presentation because this was something that had mainly been described in immunosuppressed patients, and these patients didn't have any known immunosuppression otherwise. And it was a series from October to May that this had happened in Los Angeles. And so soon after that, several months after that, there was a further case series that was published in the New England Journal of Medicine of 11 patients who presented with pneumocystis pneumonia. So the same sort of opportunistic type infection. And it was over a longer time period from 1979 to 1981. And they had different sort of social risk factors that they had identified. They had 7 who had a history of substance use disorder with intravenous drug use, and 6 who were men who had sex with men. And one of these patients, actually, in addition to the pneumocystis pneumonia, also had this unusual malignancy or cancer known as Kaposi sarcoma, which is not a common problem at all. And so this recognition sort of grew and grew. And in December, there was also a description of 5 infants in New York who were treated for a severe immunodeficiency. And at that point, at least 3 of the infants were known to have mothers who either used drugs or engaged in sex work. And so they were starting to see these epidemiologic links to this disease of immunodeficiency. And fast forward another 6-7 months, MMWR reported on patients with hemophilia A also showing up with this immunodeficiency and having similar opportunistic infections. And so in September 1982, the CDC published an initial case definition for AIDS, or acquired immunodeficiency syndrome. And it included 593 case reports that they had received from 1981 to September 1982. And 75% of the patients in the case reports were men who had sex with men, and 25%, around a quarter, reported injection drug use. And so there were starting to be a recognition of risk factors for this disease. And then in October, so the next month, there was a case series that was published in the Annals of Internal Medicine that described similar illness in women. And this was some of the, in addition to the infants that were described back in December, those weren't necessarily linked to this other series of cases that were being described, and they weren't included in the initial case definition of AIDS. But then this description in October said that there's this similar illness that seems to be occurring in women. And of the women that were reported, 4 of them themselves had injection drug use, and 1 was a sexual contact of someone who injected drugs. And so then in 1983, in May, in Science, there was a published report that there was a retrovirus, which is a particular type of virus that was identified as a possible cause of the acquired immunodeficiency syndrome, or AIDS. And then in 1984, there were further studies that established this retrovirus as the cause of AIDS. And it was then called HTLV3, or human T lymphotropic virus 3, but then since has become known as HIV, or human immunodeficiency virus. And these are out of different labs that put forth these early descriptions. And so you can see, even from the early case reports, there's a theme that HIV and AIDS has been associated with men who have sex with men, but then also with injection drug use. And that's been identified as a risk factor for the syndrome initially, and then for what became known as the infection that causes that syndrome, HIV. And so that illustrates some that we know about the HIV, and we'll go back more and talk about more of the timeline for hepatitis C, but I think it sort of introduces the concept of how these things are tied together. And so I know that from the work that you all do, you know a lot about these current trends in substance use disorder and substance use disorder deaths, but I feel like that's important to talk about some just to frame our conversation. And so I'll go through these things quickly because I feel like these things show information that you would be familiar with. And so when we look at drug overdose death rates, we see alarmingly that these have gone up over the past couple decades, and they've gone up quite a bit in the United States, and even more so in Kentucky. And this is information again from the Kaiser Family Foundation. And when we look at the overdose death rate, you see that there's been a disproportionate burden of those things in the Appalachian region, including Kentucky and West Virginia and Ohio, so places near us, and then extending down into Tennessee, and some also in other parts of the country, and very high overdose death rates per 100,000. When we look at the proportion of overdose deaths as compared to all deaths, it's striking that it's between 3 and 4% in Kentucky, and these are accidental or deaths that are preventable. And so it's one of the reasons for these presentations and something to emphasize. And again, I'm sure you are very aware of this problem as well, just with the professions and your backgrounds that you're coming from. But you see again on the map that it emphasizes the Upper Appalachian region. When we look at the opioid overdose deaths and the type of opioids, we see that there's, for natural and semi-synthetic opioids, there's been still sort of Upper Appalachians. There's been a high rate of deaths there from these natural and semi-synthetic opioids. And then when we look at overdose deaths over time, we see that there's been an increase in the synthetic opioids other than methadone, and that's happened more in the past 6-7 years or so, and this has included mostly fentanyl. These are statistics from the United States as a whole. And we see that for Kentucky, similarly, fentanyl's accounted for a lot of the overdose deaths in the past 5 to 10 years. And so, as I said, we went through that sort of fast because we know that those are things that you guys work with every day. But in terms of epidemiology, how does that mesh with the things that we saw for substance use disorder? So still, the major risk factor, even now, compared to early case descriptions, the major risk factor for HIV and also AIDS is male-to-male sexual contact. And that's been, the incidence has been fairly stable among men who have sex with men over time. It tends to have maybe tailed off a little bit over the last several years. Again, there's a gap in the data that we have in sort of present time. And so the last time that we have information for is 2019, and that's the graph that I'm showing with information from the CDC. You see that the numbers are still relatively stable for heterosexual contact and men who have sex with men and injection drug use, and then also just injection drug use as a risk factor unto itself have stayed relatively stable over time. And they have not shown the decrease necessarily that some risk factor has shown over time. When we look at women particularly as a subset, we see that heterosexual contact as a means of HIV transmission has gone down over time, that the incidence has gone down with that. But despite that improvement over time for heterosexual incidence, the incidence among women who inject drugs for HIV has stayed about the same. We haven't made the same inroads in HIV prevention for this risk group. And when we look at men versus women and their risk factors for HIV infection among adolescents and adults in 2018, again, the most recent year for which we have data, we see that for men, again, still men who have sex with men, that's the major risk factor. But that injection drug use is a significant risk as well, accounting for about 5% of new HIV infections in 2018. But the proportion is higher among women, around 15%, with 85% being from heterosexual contact. So where are we seeing new HIV infections the most? Where is this problem most magnified? And we see that this data from 2019 shows that the South is one of the areas where most of the new HIV infections have been occurring, particularly this is not per population, and so larger states tend to have some skew. But we see that North Carolina, South Carolina, Georgia, and Florida have large proportions. New York has a large number as well, but not necessarily relative to its population. When we look at the prevalence, in other words, of people who are living in the area, how many are living with HIV infection that's been diagnosed, we see again that there's a large prevalence in the South, particularly in South Carolina and Georgia, but there's also large prevalence in some of the urban areas of the North, in New York, in New Jersey. And so these are areas where people are living with HIV infection as a chronic medical problem, but also out west in California. And within the geography that we've talked about, when we look at where HIV infection is happening in terms of smaller areas or larger cities, and what are the risk factors in those areas, we see that it varies depending on sort of the rurality of a location. In larger metropolitan areas and large cities, we see that men who have sex with men, that risk factor accounts for a larger proportion of HIV infections than it does in more rural areas. In more rural areas, there's a larger proportion that's more related to injection drug use, and then also with heterosexual contact, or men who have sex with men who also have injection drug use as a risk factor. And so in a rural state like Kentucky, this is particularly relevant to us. So one of the things that brought forth the tie between substance use disorder and HIV recently has been recent HIV outbreaks that have taken place. And that's been brought to light more the problem. And so Scott County, Indiana is one of the ones that most people are familiar with. And this outbreak was reported in 2015, and it happened over sort of 2014 to 2015. And it was initially identified when 17 cases had been reported to the state health department in January of 2015. And that was in an area where not nearly that many cases had been reported in the past. And so recognizing that this was a problem, the state started an HIV testing clinic in March of that year, and they saw the link that was with substance use disorder and injection drug use. And so they started a syringe service program in April of that year. And unfortunately, at the same time, there were sort of conflicting messages that were coming from state government at that time. At the same time of opening the syringe service program, they also made syringe possession, instead of just a misdemeanor, they upgraded that to a felony offense. And so sort of a counterproductive measure in the midst of trying to handle an outbreak that's passed from shared injection paraphernalia. But overall, in this small county, Scott County, Indiana, in this relatively small time period, 2014 to 2015, there have been over 215 cases that have been attributed to this outbreak. And most of the cases have been associated with injection drug use and with sexual partners of people who inject drugs. And Scott County is not the only place where this has happened. It's happened also in some more urban areas. And so there are outbreaks that have been reported in Lawrence and Lowell County, Massachusetts, which would be a more urban area, but also an area where there's been long entrenched substance use disorder problems and homelessness. And between 2015 and 2018, linked to substance use disorder, mostly there are 184 patients who were identified with HIV infection in this area. And HIV sequencing data actually helped to show the scope of that outbreak and increased the number of patients that were actually identified as and linked to the outbreak, as opposed to sort of pre-existing other reports of cases. Similarly, it's not limited only to the United States. Worldwide, there's been problems with HIV infection linked with injection drug use. And in Scotland, they found that there was an outbreak associated with homeless facilities. And they actually used clinic services at these homeless facilities and outreach nurses to help curb an outbreak of HIV that happens there among people who inject drugs in 2014. Other outbreaks among people who inject drugs have been reported in Bucharest, Romania, and Athens, Greece, and Ireland, in Southeast Saskatchewan up in Canada, and then also in Tel Aviv, Israel. So it's not unique only to the United States, but the United States has been one of the places where it's been most reported. And many of these outbreaks have involved homeless populations who also have concomitant substance use disorder with injection use. And so in recognition of this, many of you have seen this map before. This was an analysis done by the CDC to see where there's particular vulnerability on a county level for future HIV and hepatitis C outbreaks. And they identified 220 vulnerable counties in the United States. And you see that most of them were in the Appalachian area, particularly in Kentucky, West Virginia, and Tennessee, and some in Southern Ohio. So in areas where we see people here at UK coming from those areas. And so what does that have to do with care for HIV? How do we help address these problems? And one of the ways that we conceptualize that is with the HIV care cascade. And so what we mean when we say the HIV care cascade is areas where we talk about going from people who have HIV being diagnosed with HIV, because that's the first step to get into treatment. So being tested and then being diagnosed, and then getting linked to a clinic where they're able to getting care for HIV, and then getting started on medication, and then being virally suppressed on that medication, and staying in clinic and on medication and virally suppressed. And so we want to move people from who have HIV through that cascade so that they can be suppressed. And we know that by treating people with HIV, that we decrease the risk for community transmission of HIV. And so it has pertinence to these outbreaks. And we know that there are particular challenges in getting people through this cascade who have substance use disorder as well. And so some of these next slides will sort of summarize some of that. And one of the ways that the CDC monitors this is by looking at reporting of CD4 and viral load test results. And so that's a proxy that they use in terms of our people in care. And you see from this map that the data that I'll show doesn't really include data from Kentucky because the reporting was incomplete in 2019. And so that's a caveat to the things that I'll report, but this is national data, not including Kentucky. So when we look at one of the first steps past diagnosis, so once someone's diagnosed with HIV, are they linked to clinic within 1 month? Because we know that getting people linked to clinic quickly helps get them in care and stay in care. So does that happen for patients that are diagnosed? And we see that for men who have sex with men, that happened for 80% of people who were diagnosed, but the proportion was lower for people whose risk factor for HIV infection was injection drug use. We see that it was only 76% for men and only 75% for women. Slightly better for men who had sex with men and also had injection drug use as a risk factor, but still not as good as those who just had men who have sex with men as their risk. And again, not as good for men whose risk factor was heterosexual contact. So once people are linked, what proportion of those people go on to have virologic suppression? In other words, what proportion gets started on medication, and once they have the medication, gets their viral load down to undetectable? When we treat HIV, that's one of the things that we monitor. We monitor to see whether or not on treatment, the medicine that we're giving patients with HIV keeps the virus from making more of itself. And so one of the things that we know we're having success with treatment is if they're undetectable, if they have virologic suppression. And so that's what this is looking at as a step in the cascade. And we see that, again, there's a larger proportion of people living with HIV who have male-to-male sexual contact as a risk factor for their infection, who get in care and have HIV virologic suppression at 6 months. We see that that's about 68% for that risk, people who fall into that risk factor, and that the proportion of people with virologic suppression who have other risk factors for HIV acquisition is less. We have much less success for people who have injection drug use as a risk factor. We see that for men with injection drug use as a risk factor, it's only around 52%, and not much better for women with a risk factor of around 54%. And then when we look overall at the cascade, we say receipt of care, so being seen in clinic for HIV, being retained in care, in other words, staying and having repeated visits and repeated measurements of viral load, and having virologic suppression. So we're looking at all three of those things by risk factors in this graph for these 41 states who have reported data to the CDC in 2018. We see that the steps are less for those who have injection drug use as their risk factor, as opposed to male-to-male sexual contact. We see that instead of being 77% for the male-to-male sexual contact, it's only 64% for injection drug use. And that, again, the virologic suppression is less, instead of 67% down at 53% for men, and only slightly better for women. And so we have a long way to go in terms of getting patients with injection drug use who have HIV engaged in care and retained in care and virologically suppressed for their own health and for community health to prevent onward transmission. So speaking particularly to that, when we talk about HIV control or virologic control, substance use is associated with non-persistence in HIV treatment. In other words, falling out of care. There are different definitions that we have to define falling out of care. Most of it has to do with whether or not someone's had 2 visits within HIV clinic within the past 12 months, or if they've had one within 6 months. And that's been less so for people who have substance use disorder co-occurring with HIV. And that's not necessarily specific to injection drug use. That can be other routes of use as well. And substance use is also associated with less consistent HIV virologic suppression. And so again, that's one of the measures that we have of how effectively we're treating people for their HIV. And we find that we don't have as much effectiveness for that. And it also has been shown to be a risk for how infectious someone is to pass their HIV on to someone else. And so substance use is a risk factor for less engagement in care, less consistent virologic suppression, and higher risk for onward transmission of HIV. And substance use, not surprisingly, with these 2 prior statements I've made, is associated with faster progression from just HIV infection itself to AIDS, which is sort of a manifestation of immune deficiency from the HIV infection. And it's also associated with increased mortality among those who are infected with HIV, and that's particularly been shown for the veteran population. Stimulant use has been associated, we talked some about opioid use, but stimulant use has been associated with an increased risk of progression to AIDS and death among HIV-infected men who are starting antiretroviral therapy for their HIV. And sort of, again, reiterating what we spoke about earlier, illicit drug use is associated with poor retention and care. And so looking at a statewide level, this was some information that was present from Tennessee. And so when they look at sort of what in their state is associated with linkage to care, retention and care, and virologic suppression, and they looked at it dependent upon risk factor, they saw that for men who have sex with men, that risk factor was associated with better linkage to care, again, compared to being heterosexual sex as a risk factor, about 7% better, and better virologic suppression. But when we looked at injection drug use as a risk factor for HIV transmission, we saw that it was not as good. Again, only less than 10%, or 10% less who were able to be virologically suppressed, dependent upon that risk factor. So reflecting sort of what we see in the nation as a whole. So what about HIV transmission? And I've touched on this some as we've gone through some of the epidemiology and the care cascade, but we'll talk some about transmission particularly. So what is the risk of passing HIV from one person to another by exposure route? And so it depends. It's not the same dependent upon each exposure route. The risk for passing it by parenteral routes tends to be higher than the risk for sexual routes, except for receptive anal intercourse. And so the highest risk is for blood transfusions. And so now, blood transfusions in the United States are screened for HIV, but of course, when HIV was first being described, they weren't. And so that was a major risk factor for HIV transmission. That's one of the reasons hemophilia was so highly associated with HIV infection early on. And the risk for transmission is very high. Of 10,000 people who were exposed, over 9,000 who were exposed by blood transfusion became infected. And that's a pretty good, that's much higher than any of these other exposure routes. But when we talk about needle sharing for injection drug use, the risk is high as well. Around 63 out of 10,000 exposures result in an HIV infection. And a percutaneous needle stick is less than that. These are more the types of needle sticks that we would have from healthcare accidental exposures and everything occupational related exposures. For sexual exposure, the risk is higher for receptive sexual intercourse than it is for insertive. You see that that's definitely true for anal intercourse, but also true for penile-vaginal intercourse as well. The risk with oral sex is very, very low. They don't offer a number per 10,000 exposures. There have been some instances where it's felt that that's perhaps the risk factor for transmission for an individual patient. A lot of those have been more with sort of ulcerated oral mucosa, problems like that, as maybe a blood or percutaneous exposure as opposed to just the mucosal exposure. The risk for vertical transmission is also quite high from mother to child. In the absence of any kind of treatment for mom or for baby, that risk is significant, around 20%. So, and you see that here around this 2,200 out of 10,000 exposures. But for children who were born to mothers who were on HIV medication prior to pregnancy and stay on medication throughout their pregnancy, and the children get appropriate prophylaxis, the risk approaches 1%. And so that's a preventable transmission, and important to emphasize as a way to prevent onward transmission of HIV. So what are injection behaviors? Again, this is a busy slide, but there are several things that I think are pertinent to point out. What injection behaviors are most associated with HIV transmission, and what are the ones that are reported by people who already have HIV? And we see that sharing of vaccines is a significant concern. So this is reported by people who have HIV. They reported distributive sharing of syringes. In other words, they would get them and then pass them out to others and everything for reuse. And then distributive sharing of non-syringe injection equipment was also a significant risk factor. And then, as many people probably recognize, injection drug use around the time of sex is also a high risk factor, and reported commonly among HIV infected persons who inject drugs. And the source of syringes when people got them varies, but we see that worryingly, there's a significant proportion of people who have HIV that got their syringes from friends, relatives, or sexual partners, or who got them from their dealers or at shooting galleries or off the street. So worrying for onward transmission of HIV. And so going on through the same chart, but broken it down into two slides, when we look at transmission as it relates to substance use disorder, particularly injection drug use, what happens with those syringes? Worryingly, there's a significant proportion of people who put these syringes and these needles in places that aren't intended for medical waste. That was the proportion, that was the larger proportion of what happened with them. But there is some proportion that took it to a syringe service program. There was a significant proportion of people who felt, who had HIV that participated in the survey that felt they needed drug or alcohol treatment. But again, sadly, there's a small proportion who felt that actually obtained it or enrolled in medication-assisted treatment. And so we see that there's these risk factors, particularly for substance use disorder and HIV transmission. And just to sort of make sense more of what we're talking about with the virologic suppression and transmission, I want to briefly touch on HIV pathogenesis. And so this is a slide that talks about the HIV life cycle. And I promise I won't dwell on this very long because most people don't like looking at these things. But it is pertinent, and I think it does have importance when we think about how HIV gets transmitted and what we mean when we talk about HIV control. And so there's different parts of the life cycle. The first part talks about this HIV virus and how it binds to cells. And so it has different receptors and co-receptors that it binds on the cells in the human body. It binds something called a CD4 receptor, and that's the primary receptor that it binds. It also has co-receptors that it binds with. Those can include these CCR5, these CCR5 receptors that can also be on the cell surface. Once it binds, it then fuses with the cell surface, and it takes the genetic material and proteins from the virus into our cells. And so that's a process through this fusion. And then inside the cell, we have the HIV RNA, and then we also have this enzyme from the HIV virus called a reverse transcriptase. And the reverse transcriptase takes the HIV RNA and it makes it into HIV proviral DNA. And so it goes backwards from what our bodies typically do. And then this HIV DNA then goes into the nucleus of our cells and it gets incorporated into our genome. And so it gets linked in, and you see that here where it's put in as part of our genome. And then once the cell becomes activated, our our bodies, our enzymes transcribe this HIV DNA into RNA, which is then sliced and assembled and translated out into new virions. And it makes this protease, which cleaves the proteins that are needed to make a mature virion. And then these bud off of the cell and then go on to infect other cells. And so it's pertinent to understand this because there's different parts of the life cycle where our medications interrupts what the virus does, and that's how we treat it. And it's also pertinent to know because there are different ways that people can take medications that prevent it from being passed on, and they interrupt at different parts of this life cycle. So one thing that's important to know about the pathogenesis of HIV is that it's a very variable virus. And so when we sequence HIV DNA that's in our cells, we find that it mutates a lot. It mutates at a rate of around 4.1 thousandths of mutations per base per cell. And so that's actually quite a bit. That's much more than we mutate in terms of our DNA. And these mutations allow the HIV, it's not a single clone that's infecting anybody. It's a huge population of lots of related clones, but they're sort of all like cousins that are all a little bit different. And this variability allows the virus to get around our immune system because if our immune system latches onto a single part of a clone, it's not able to block all of the different clones that are infecting a person. The variability also is pertinent in terms of how it relates to how we treat HIV. Because all these mutations are happening every time, it's possible for the mutations to make it so that a medication that someone's receiving that might otherwise have kept the virus from making more of itself, well, it has another mutant variety that the medication doesn't work against. And so because of the variability that HIV has, that's why it's important that people are on multiple medications to sort of cut off the routes of escape that the virus has at multiple points. And it's also important that HIV infected patients are adherent to their medications, because if we think about what happens if they take medication on and off and on and off, what happens is that the levels of those medications go up and down in that person's body. And so there are points in time where the HIV virus that they have is exposed to low levels of that medication, which might be enough so that mutations can arise, but not enough to really keep the virus under control. And so over time, when those mutations arise, that makes it so that the medications we were initially treating the patient with that were having effect no longer work. And it makes it so that, again, their viral load goes up, and again, they're able to transmit the HIV on to other people. And so those are sort of two pertinent clinical manifestations of what the variability means for individual patients. And just sort of thinking about how often this happens, there are around 9,200 to 9,600 nucleotides in the genome of HIV-1, and there are about 1 to 2 generations of HIV each day. And so if there's a viral load of 100,000, so that you can think about how many new virions are being made every day, and you can think about how often the virus completely changes its genome in a given day, and that sort of gives you an idea of how important this mutation is, this mutation rate is to maintaining the HIV infection. So we've sort of touched some on treatment, and we've touched some on the importance of variability to treatment and the importance of treatment adherence to treatment success for folks with HIV. And so I'll talk some, again, more just about sort of the history of treatment. You remember that when we first started out, we talked about a timeline for HIV, and we started back in 1981 when the first cases were described. Well, there was a gap in time from 1981 until 1987 before we had any kind of medication that was available for treating HIV. And the first medication that became available was Zidovudine. And then in years following that, 4 years later, we started getting other medications that were in the same class, or nucleoside reverse transcriptase inhibitors. And so you see we got sort of 3 of them that happened in the 90s. And then later in the 90s, we started picking up more different medications, and we picked them up in different classes. And so instead of working just on this single enzyme, the nucleoside reverse transcriptor or the reverse transcriptase, we started getting other medicines, this sequinavir that worked on the protease, which is a different part. And so over time, we've gotten more and more medications in our armamentarium to be able to treat HIV. And that's helped us because we're able to have more options to cut off this extremely variable virus at multiple points in its life cycle. And if people have problems with side effects from a single medication, then we're better able now to offer them options for other medications than what we were initially. So that now, even in the past 10 years, you see that there's lots of medications that have come out for treatment for HIV. And so going from medications that had significant side effects that people had to take multiple times a day and weren't very effective, now we have medications that come in fixed dose combinations. So there's multiple medications in a single tablet that people can take one time a day and are effective and generally don't cause people that many side effects. And so that's helped tremendously in our ability to treat HIV. And again, this life cycle diagram that I'd shown a few slides ago sort of emphasizes the different points at which we have medicines that block the HIV. We have some that block up here at binding, CCR5 antagonists. We also have a CD4 antagonist that's available now. We have some that work on fusion, and so some fusion inhibitors. We have lots of medicines that work at this reverse transcription step right here, where it blocks this enzyme that's unique to the virus, this reverse transcriptase. We have 2 different classes of medicines that work there. We have a newer class of medication that works at this integration step, where before the HIV proviral DNA is integrated into our DNA. And then we have other medications that work at this protease step out here with budding, and also ones that inhibit budding in a different kind of way. We have some more information about HIV prevention. Sorry, there we go. All right. So when we talk about HIV prevention, how can we prevent onward transmission of HIV? Well, it depends upon the routes of transmission. When we talk about sexual transmission, condoms have been shown from early in the epidemic that those are highly effective if they're used properly. It's hard to estimate exactly how effective they are, just because sometimes it's difficult to tell how appropriately they're used. But they're most effective if they're used for the entirety of sex from the beginning to the end and with every sexual act, as opposed to intermittent or just partial use during sex. For those whose risk factor is injection drug use, we know that syringe service programs have been shown to be effective for preventing HIV transmission. Actually, that's been shown to be about 66% effective in areas with high coverage for syringe service programs. Again, these are things that only can be looked at sort of from a larger public health perspective as opposed to a single individual viewpoint. And we know that medication for opioid use disorder, even beyond syringe service programs, if people are on medication for opioid use disorder, if that's their risk factor for HIV acquisition, that them being on it results in a 54% reduction of them developing HIV infection. And that's even synergistic if it happens in a place where there's accessibility for syringe service programs and accessibility for medication for opioid use disorder. So these measures are effective at preventing onward transmission of HIV. And then apart from those things that are known for people who are at risk but do not yet have HIV, there's ways that we can prevent HIV transmission by effectively treating people who already have the infection. And so this gets at U equals U, which stands for undetectable as untransmissible. And this is something that the CDC has put forth based on studies that have come out over the past 10 years or so. There are multiple studies that have shown that for sexual transmission, people who are on who are on HIV treatment for their HIV and have a suppressed or undetectable viral load, their risk of passing HIV on to their sexual partners is essentially 0%. And that's been shown for multiple different types of sex, whether it be men who have sex with men or with heterosexual sex. As I mentioned earlier on, U equals U, sort of the first way that this was described was in pregnancy and labor and delivery. We know that women who have HIV, if they are on medication and virologically suppressed from the time of conception all the way through delivery, and their children get medication for prophylaxis, the risk is much less than 1% for them passing HIV on to their children. There's actually cohort studies from France showing that for women for whom that's true, the risk was well under 1 in 1,000. So that's strong encouragement to be able to share with women who are in that situation. For people who have injection drug use, for their risk factor for onward transmission and sharing syringes, we don't have as much direct information, but we feel that this is likely the risk is reduced for people who are on suppressive treatment for their HIV. And we know that also looking at the perinatal transmission, that breastfeeding, the risk is greatly reduced for women who are on medication for their HIV. It does not reduce it all the way to 0 like it does for sex and for other perinatal transmission risk factors, but it does reduce it dramatically. And so that's an important point, and that makes the HIV care cascade that much more important for how we do in terms of public health as opposed to just individual health. Apart from how we treat people who have HIV themselves, we can also give medication to people who are at risk for getting HIV, and that can be either at risk for sexual transmission or for parenteral transmission, like through injection drug use. And so PrEP stands for pre-exposure prophylaxis for HIV, and it's a daily medication, and the medication can be either a fixed dose combination of intracitabine and tenofovir disoproxil fumarate or intracitabine and tenofovir alafenamide. The tenofovir alafenamide is more, or Descovy, that's more for men and transgender women as opposed to the earlier version, or the Truvada, which is more for women. We know that giving this has been shown to decrease the transmission of HIV, and I'll show you some of the data in terms of how much. There's also newer options for PrEP. There's a newer medication called cabotegravir, which is available for injection, and the injection can be given at the initial injection and then 4 weeks later, and then every 2 months. And that's been shown to be effective among men who are at risk for getting HIV. And these medications, they're indicated for sexually active adolescents and adults who have had a bacterial STI, whether that be chlamydia or syphilis or gonorrhea. They're indicated for folks who have had that within the past 6 months, or those who have inconsistent condom use, or if someone has a known HIV positive sexual partner, that's indicated. They're indicated to get PrEP. So that's a lot of people. It's also indicated for persons who inject drugs and share their injection equipment, and so also a lot of people. Before we prescribe PrEP, because these medications are medications that work sort of partially against the HIV, we want to make sure that someone's not actually HIV infected. If they were HIV infected, then we want to get them on full treatment for HIV as opposed to just PrEP. And then we want to make sure that they continue to get tested for HIV while they're on this medication. And so that means that they need to have follow-up visits every 3 months, both for HIV testing and for testing for other sexually transmitted infections and other infections that might be associated with risk factors that are common for HIV. And so what's the data? How effective is PrEP? And so for pre-exposure prophylaxis, these are different trials that have been done. They've been mainly done among patients that have men who have sex with men as their primary risk factor. And so this IPREX and this partners PrEP, these are for sexual risk factors, particularly men who have sex with men. they found that the overall effectiveness was around 75% or 44%, but if they had detectable levels of medication in the blood, the effectiveness was greater than 90%. And so, like most medicines, they are effective mostly if you take them. There's other data about intermittent PrEP that's shown that it's not necessarily something that people have to take every day, but it depends on the route of exposure. For maximum effectiveness for PrEP to prevent HIV transmission by receptive anal sex, people have to take it for about 7 days before their exposure for it to be most effective. For receptive vaginal sex and for injection drug use, to get blood levels that are stable and everything, the patient has to take the medication for about 21 days prior to their exposure for it to have maximum effectiveness. And the effectiveness has been a bit lower when we look at it among people who have injection drug use as a risk factor. This TDF2 trial was actually done mainly among those patients, and also this BTS trial was done mainly among patients with injection drug use as their risk factor. And you see that the effectiveness was a bit lower, even when we only take into account those who had detectable blood levels. Some of that probably has to do with just the intensity of exposure and also the need for a longer period of time ahead of time to be on the medication prior to exposure for effectiveness. And so we have this tool to help prevent HIV transmission. How many people are actually getting it? And you see that not a lot. When we look at the percentage of people who are out there that have indications for PrEP and are actually on it, only about 10% in Kentucky, this was as of 2018, are actually on PrEP. And that's lower than the national average of around 18%. There are other places in the country where there's a larger proportion of people who are getting PrEP. You see that that's the case in New York, around 40%, in California with 20%. But fortunately, in some of the areas where they're the highest incidence rates of HIV, there's some of the lowest PrEP uptake rates. All right, so we've talked a lot about HIV. I was going to move on to talk more about hepatitis C and its linkage with substance use disorder and injection drug use. So similar to HIV, I was going to talk about the hepatitis C discovery timeline and sort of emphasize some about how it's been tied with substance use disorder, even from sort of the beginning. And so hepatitis C is kind of interesting. We've known about hepatitis since earlier on, and there were two different types of hepatitis that were described initially. One was defined as hepatitis A and one was defined as hepatitis B, and they were defined epidemiologically by different routes of transmission. A was defined as a fecal oral route of transmission or a food route of transmission, and B was defined as a parenteral route or a mother to child route of transmission or through sexual contact. A also was passed through sexual contact. And also they were defined in terms of the likely outcome. And so hepatitis A was identified as an infection that had an acute component, but no chronic component. Hepatitis B was identified as an infection that had some people who had acute hepatitis, but more people who developed a chronic component. And so proteins from the virus that was associated with hepatitis B were actually discovered in 1963. And that's when an assay was developed to screen the blood supply for hepatitis B. And then in 1970s, a virus was identified that caused hepatitis A. And so despite this and screening for hepatitis A and B, there were still people who were getting blood transfusions that had transfusion-associated episodes of hepatitis. And so among those people, they were described as having non-A, non-B hepatitis. And typically these patients did not have acute symptoms, but they oftentimes ended up having chronic liver disease. And so that was sort of different from the A and B that we knew about already. And so before they identified what actually was the cause of this, there were actually efforts towards, could we do anything to treat it? And so interferon alpha was something that had been found to be effective partially effective for treating hepatitis B. And so it was tried for this non-A, non-B hepatitis in 1984. And there was actually some success that they found with this interferon. But it wasn't complete success. And so then with some continued work, a continued look at virology and everything, in 1989, they actually identified hepatitis C as one of the most prominent causes of non-A, non-B hepatitis, particularly transfusion-associated hepatitis. And so now, of course, our blood supplies are screened for hepatitis C, but that was not the case previously. And so we look at hepatitis C epidemiology, we'll look at sort of overall trends in the diagnosis, and then also more trends in terms of how it's passed from person to person, from both a national level and some on the Kentucky level. So the incidence or the report of acute hepatitis C infections has increased over time. It's pertinent to point out that most people who get hepatitis C don't have an acute manifestation of it. They don't show symptoms right away when they get the infection. They develop the infection and they develop chronic problems, but they don't sort of know it up front. And so this incidence that we're reporting of acute hepatitis C does not capture all of people who are developing incident HIV or hepatitis C infections. But we see that even though it's an imperfect marker, it has been increasing over time. Since 2012 to 2019, you see that there's been some increase in reported cases, but then this actual, this estimate of acute infections has gone up even more so. And not all states report this, so we're not getting perfect capture from that either. When we look at the rates of reported acute hepatitis C by state or jurisdiction, you see again sort of a common theme that we had pointed out before from our substance use slides, that Appalachia is an area where there's been more intense transmission. And so there's also been more reported cases of acute hepatitis C from Kentucky, West Virginia, Indiana, Ohio, but also in some other areas where there's been significant injection drug use problems, such as Maine. And previously, there had been a description of sort of this age cohort of people who were likely to have hepatitis C, and that was in the baby boomer cohort. And so that would fall in this sort of 50 to 70-year-old age range. And you see that there still is a number of people who have that in this age range, but these new cases are actually being reported more in younger people and in people who are even in their 20s, early 30s. And it's been reported more in men as opposed to women. And this is with chronic hepatitis C infection. And so in response to that, there's been changes in how the CDC recommends and the ACIP recommends testing, the US PTSD, PTSF recommends testing for hepatitis C instead of just testing this cohort of people with reported risk factors. Now there's recommendations to test everybody, all adults, for hepatitis C. And so what about hepatitis C transmission? The estimated risk, well, it's higher than it is for HIV. For a needle stick injury or a cut with exposure to hepatitis C infected blood, the risk is almost 2%. The risk is a bit lower for mother to baby transmission. Again, that's around 5 to 6%, and that's for women who have active hepatitis C infection, not those who don't have a viral load. But there's minimal risk for transmission through heterosexual sex. There are studies that have followed monogamous heterosexual couples who have discordance in terms of their hepatitis C infection, one with hepatitis C and one without. And over a 10-year period, when they followed this almost 900 couples, they found that there were no transmissions. And so that would indicate that the risk is very low for heterosexual sex. It's hard to say that it's zero, but probably very low. There is a higher risk that's been reported for anal sex. Again, it's been hard to quantify what that risk is, but it does tend to be higher. And so we've talked about HIV, we talked about the transmission, now we'll talk about the life cycle for hepatitis C as well. Similar to HIV, there's a phase of attachment, and then there's this phase of endocytosis where our cells actually take in the hepatitis C virus more actively than is the case for HIV. And then there's an uncoding of the virus, and the hepatitis C is an RNA virus. It's not a reverse or a retrovirus. And so it actually all happens out in the cytoplasm. And so there's an uncoding in the RNAs in the cytoplasm. Then we translate, our enzymes translate this RNA into protein. And it also there's an enzyme that the virus has that causes replication of its RNA. It has an RNA-dependent RNA polymerase. And then these proteins and the RNA that's newly made assemble and mature into viruses that are then released. And so we have medications that work at different parts of this life cycle. Most of our medications work at this replication part of the life cycle, but then we have some that work at this maturation and assembly part of the life cycle. So when we talk about what happens when someone's infected with hepatitis C, this is different than what happens when someone's infected with HIV. About 55 to 85% of people who are infected with hepatitis C go on to develop chronic infection. That means that 15 to 65% of people who are infected actually clear the infection on their own. As we said earlier, most of the people who get hepatitis C infection, they actually don't have any kind of acute illness. Those that do have acute illness with the infection are actually more likely to clear it on their own. And then after someone develops the chronic infection, of those people who do, there's about 20 to 30% of those patients who have chronic infection that will go on to develop cirrhosis. And that doesn't happen quickly. Typically, the progression takes 20 to 30 years. And so people live with this chronic hepatitis C infection over time before they develop any manifestations with it. The progression tends to happen faster in people who are older and have more obesity. And also if they have other liver toxins. So in other words, in people who drink heavy alcohol, or if they take other medications that cause higher risk for liver toxicity, they have a greater risk for progression to cirrhosis, and the cirrhosis tends to happen faster in those patients. Once someone has cirrhosis, there's about a 1 to 4% chance that those folks each year will develop liver cancer, or a type of liver cancer called hepatocellular carcinoma. And there's about a 2 to 5% chance that they will decompensate. In other words, that they'll get sick from their cirrhosis. There are many people who have cirrhosis or fibrosis of their liver who don't necessarily have a lot of clinical manifestations of that, but then when they decompensate, that's when they get sick from it. And so you see that there's a long progression time, 20 to 30 years before you even get to cirrhosis, and then sort of a small tick over each year among those who have cirrhosis that get sick from it. And so this is a type of infection that sort of stays underneath the surface and isn't detected unless we do screening, but it's doing damage sort of all along. Apart from the damage that it does in the liver itself, hepatitis C can also be associated with other manifestations outside the liver. It can cause a vasculitis type problem or an autoimmune type problem called cryoglobulinemia, and that can cause kidney failure. It can cause rashes. It can be associated with an arthritis. It can also cause different problems with the kidneys, one called membranoproliferative glomerulonephritis. So that can cause progressive kidney disease. This leukocytoclastic vasculitis that I have listed here, that's talking about a skin disease, which can be very painful for people and cause sort of a bruising type appearance. It can also cause another skin type disease called porphyria cutanea tarda. That's sort of a sun-sensitive skin disease that people can get that can cause blisters in sun-exposed areas. It can cause another type of skin manifestation, something called lichen planus, which is like an intensely itchy rash that people get oftentimes sort of on the insides of their elbows and everything, and also on extensor surfaces, so over the outside of their elbows and on their knees. And then there's extra risk for people with hepatitis C to get other common medical problems. For instance, diabetes is about 1.7-fold higher risk for developing that among people who have hepatitis C as opposed to people who don't have hepatitis C. And so all of these things add up to, even beyond the risk for liver disease that hepatitis C poses, it poses other risks for cardiovascular disease and endocrine comorbidities. And then also there's risk for different types of cancer, and it's not just cancer of the liver, there's risk for different lymphomas. There's some types of lymphomas, particularly this marginal zone lymphoma that I mentioned here, that are sort of slower, more slowly progressive lymphomas. And in some instances, treatment of the hepatitis C has been shown to result in regression of the lymphoma. And so treating the infection can sort of cure the malignancy. Not in all cases, but in some. And for the cryoglobulinemia and for these leukocytoclastic vasculitis and these other kidney problems that are associated with hepatitis C, there have been trials that have shown that treating the hepatitis C can make these other problems get better as well. And so all the more reason to want people to get on hepatitis C treatment. And so what about hepatitis C treatment? I'm only going to mention this briefly, but I think it's important that everybody knows, particularly people who are seeing people who have hepatitis C, that we have good treatment for hepatitis C that's available right now. There are different types of hepatitis C, and it used to be, we call those genotypes. It used to be that we had different medicines for the different types, but now there are medicines that are pan-genotypic, meaning that the same medicine can work for all the different genotypes, and that there's high success rates even with all these different genotypes, some of which didn't used to have as high success rates. When we define what we mean by success, some of the terminology we'll use is something called a sustained virologic response at 12 weeks, or an SVR12. And so that means that someone takes the treatment typically for 8 to 12 weeks. And then after they finish it, they wait another 12 weeks, or almost 3 months. And then they get another hepatitis C viral load test at that point. And that's when we know if the viral load is negative at that point. If we can't detect the virus at that point, that's when we know whether or not we had success with the hepatitis C treatment. That defines cure. And so that's something that I'll reference in these next several slides. And so I just want to make sure that we're on the same page for what that means. And so this is looking at that. So this is looking at multiple different studies, and it's looking at real world effectiveness. If we look at sort of the studies that got the medicines approved, we know that they work in over 95% of people who take the medications. So how does that play out into real life? We know that the people that are included in clinical trials oftentimes aren't sort of the same as the people that we treat every day in the clinic, or the people that we see at syringe service programs. So how well do the medications work in those settings? And so in Taiwan, they've kept registries for people who have been treated with different medications. And so the sofosbuvir, the Sofvel, is one type of medication that works for all the different genotypes of hepatitis C. This GLC-PIB, or glecaprevir pibrenofusp, is another type of regimen that works for all the different genotypes. And when we look at the SVR12 rate, we see that there, where they have sort of more inclusive healthcare system, that they saw excellent cure rates, up over 95% for people who are on these medications. And that even includes people who had advanced liver disease, around 15% who had cirrhosis. So what about in other settings? What about in settings where there are people who are more socioeconomically disadvantaged? So this Tayside study was done in Scotland, and it was actually a scale-up project among people who inject drugs. And so they have socioeconomic barriers to care. And they found that among this population, there was a relatively low number of people who had cirrhosis. There were more younger people who hadn't had the infection necessarily for that long. But they still had success, even though there were people who had these socioeconomic barriers to care. They had success in greater than 80%. And so that's excellent. That's great news. And we know that in this study, a lot of the people who didn't have success, this gap between the 80 to 100%, a lot of that was because of people who didn't actually get this testing that was done 12 weeks after they finished treatment. Among people who got the testing at the 12 weeks after treatment, the effectiveness was actually 91%. And so that's really encouraging. It means that probably all these people who are sort of being counted as this sort of 20% of people, almost 20% of people that don't have SVR12, many of them may actually have been cured. We just don't know. They didn't come back for the labs to get checked so that we would know yes or no. This is showing data for Alaskan Natives and American Indians that were treated in Alaska. And you see that this is a smaller study, only around 500%. But among this sort of disadvantaged population, there was still a high SVR12 rate of around 95%. In this Australian national cohort, this REACH-C, there was a major effort in Australia to improve accessibility for hepatitis C, and that included treatment in sort of non-traditional settings. And so that meant treating people through SSP-linked programs, treating people through nurse-led programs, treating people in more community-based programs than just at specialist offices, also treating people through their primary care offices. And we found that even in sort of these non-traditional settings of care, that there was still excellent response rates, upwards of 80%. And again, this is among people who had available data to say yes or no, were they cured, who had that testing that was 3 months after they finished the treatment. That data was only available for about 85% of people. For people who had the data available, 95% of the people who had the data available actually had cure. And the same for this English cohort of people who had treatment for hepatitis C. We see that it's around this 80%. And one thing that's pertinent, even in this English cohort, one point that they made in this paper was that this includes people who got partial treatment as well. So in real life, not everybody finishes their 12 weeks of treatment. Sometimes we lose contact with people. Sometimes people lose their medicine. Sometimes people just quit taking it. And they found that even among people who didn't finish their 12 weeks of treatment, 80% still had cure of their hepatitis C. So that's really good. That's an encouraging thing to know. Of course, the more that they took of the treatment, the more likely it was to be effective. But even if we can get people, I don't think that shouldn't be our goal. Our goal shouldn't be partial treatment, but I think that we can be encouraged by the fact that even if people aren't able to finish because of interruptions or things like that, it's still possible that we're able to cure them from their hepatitis C. And so with the availability of these medications and sort of the recognition that there's a need to provide treatment sometimes to people that are difficult to reach, there was a study called the MIN-MON study, which stands for minimal monitoring. And it was a multinational study done in the United States and these other sites that I mentioned here. And it enrolled adults who had active hepatitis C infection. It used this pan-genotypic regimen that we mentioned before, the sofosbuvir-velpatasvir fixed dose combination. So that's one pill once a day that people take for 12 weeks. And in this minimal monitoring, people were started on medication, and then they had remote contact with these patients. In other words, sort of like a phone call at 4 weeks and then at 22 weeks. And that's all the contact that they had. And then they came back for this week 24. And so that's again, sort of the 12 weeks post-treatment. And they checked how many of those people actually had cure of their infection. And again, they found that 95% of people had cure of their infection. And even with this minimal monitoring, without regular visits during treatment, they found that only 15 patients, or 4%, had unplanned visits. And none of the unplanned visits that they had for concerns were treatment related. And so these medications, they're effective, they're safe, and we can do it without having intense follow-up. And it's just an encouragement for us not to delay in treating people. So what about people who have substance use disorder? That's one of the focuses of this presentation. What about hepatitis C treatment success among those patients? I referenced that in Scotland earlier. Well, just some of the themes that we've seen for people who have a substance use disorder, they're less likely to be initiated on treatment for their hepatitis C with these direct acting antivirals. We know that earlier when the treatments became available, there were some barriers from payers where they wanted to see people have negative drug screens and things like that. Those barriers are no longer in place. We do know that people who are on medication for opioid use disorder, if they have substance use disorder and opioid use disorder, that can increase linkage to hepatitis C care among people who inject drugs with hepatitis C. But even among people who are already receiving medication for opioid use disorder, there's still a gap. There's still a good number of people who are on those medications, but still have hepatitis C for which they have not been treated. And so there's still opportunity for those people to get treated and address this major health problem that they have. There has been some data looking at what about treatment in the United States in sort of atypical or non-traditional locations. What about treatment within SSPs? And so there's been treatment within these SSPs, and that's been shown to improve access to treatment, been shown to improve the proportion of people that get through treatment and have success. And that's even in comparison to the study that I'm particularly thinking about here, is in comparison to having navigators at the SSPs that link people to hepatitis C treatment outside of their SSP clinic. And so with MOUD, the treatment is highly effective. It works no less well for people who have substance use disorder than for people who don't. So again, we mentioned sort of what are the barriers? Why do people who inject drugs have hepatitis C and not get treated? Some of the barriers come from people themselves. This is data, some from Dr. Havens and everything. So there's a fear of medical establishments and a fear of wanting to engage in medical care and what the judgment that they might receive there. There's also just the competing basic needs for housing, food, and then there's a lack of symptoms that people might be having from the hepatitis C. Like we say, this is an infection that sort of tends to run below the surface until people have sort of advanced liver disease. And then oftentimes they're seeing physicians who prescribe medication for opioid use disorder who don't treat hepatitis C. And so this was a survey that was done of different people who prescribed medication for opioid use disorder. And there's a significant proportion of people who don't treat hepatitis C, despite it being much simplified now. And so that's something that we can work on as a healthcare system. And then many physicians who do prescribe medication for opioid use disorder, and they report barriers to providing hepatitis C treatment, being that they don't have great access for venipuncture for people who inject drugs. And also they don't have point of care testing necessarily for hepatitis C. There is point of care testing that's available for the first step of hepatitis C testing. So right now there's sort of two-step testing that's recommended. There's an antibody test that's done first, and that looks for the body's response to the infection or antibodies that we make. But then people who have a positive antibody then need to have testing for hepatitis C viral load. And that detects people who have actually active infection. As we mentioned before, there's a proportion of people who are infected with hepatitis C that then clear the infection on their own. And so they will have positive antibodies, but not positive viral loads. It's also possible for people, of course, to be cured through treatment. And so those people will still have positive antibodies, but they will have negative viral loads. And so to determine if someone's actually infected, actively infected, you have to have a viral load test. And in the United States, there's not a point of care test that's available for that right now, except in research settings. There is a test that's point of care that's available internationally. We're hopeful that it'll come to the United States soon. That might help to address that one barrier. And then also there's problems apart from just this testing for the hepatitis C and the need for venipuncture for that, but non-invasive liver disease assessment testing. In other words, earlier recommendations in the guidelines of how we treat hepatitis C recommended different types of liver scans to assess how much fibrosis there was, and that recommended sort of different treatment tracks. Now that's not as much of an issue. There's been simplification of the hepatitis C treatment guidelines. We're still supposed to assess people for liver disease and how and stage their liver fibrosis, but where that falls in the algorithm isn't as much of a barrier. It shouldn't be as much of a barrier anymore. One of the other barriers that people sometimes bring up is the risk for reinfection. And so certainly someone who has hepatitis C, it's possible for them to get treated and cured, but they can certainly get their infection again. And so that's been cited as a worry that people have. So what if we treat these people, but then they get reinfected? Well, then we're back in the same place we were before. That's sort of the line of reasoning that people sometimes use as a reason not to treat people who inject drugs who have hepatitis C. But really the rates of reinfection have been low in areas where there's high treatment access. And so that means high treatment access for their substance use disorder, high treatment access for their hepatitis C, and also access to syringe service programs. The reinfection rate has been around 3.1 per 100 person years reported. So it's still significant, but it's still low. And again, if people are actively injecting, this is also an opportunity for public health. If we're able to cure them from their hepatitis C, then they're not able to pass it on. And so those are perhaps, from a public health standpoint, even more people that we should be targeting for treatment to try to prevent onward transmission. And so in terms of prevention, we know that there is a reduction in hepatitis C incident infections in people who are on medication for opioid use disorder. It's been shown to be around a 50% reduction. We also know that there's a reduction in areas where there's high coverage for both medication for opioid use disorder and syringe service programs. That's been shown to be around 74%. And so it is important to have not just one, but both for preventing onward transmission of hepatitis C. And so we've covered a lot of different ground. We've talked about some of the early history of HIV and hepatitis C, and sort of highlighted their associations with substance use disorder, even from around the time they were first discovered. We've talked about epidemiologic trends for HIV and hepatitis C and substance use disorder. We've talked about the transmission, the pathogenesis, and the treatment for HIV and for hepatitis C. And so those were sort of the objectives we had.